The optic chiasma is formed from the merging of the two optic nerves. Because of its resemblance to the Greek letter chi, resembling the letter X, Galen in the 2nd century called it chiasma, meaning to cross or crossing in Greek. Hi, I'm Dr. Bijuraju and I thank you for your interest in this video. Did you know it was Sir Isaac Newton who first proposed that the fibers of the optic nerve cross or decussate in the chiasma, and that it was Ramon y Cajal, the father of neuroscience, who saw the chiasm as a structure that corrected the inversion of the sensory space imposed by the optical system of the eye. Why the fibers cross is another mystery that has been, in part, answered by the so-called somatic twist theory. The arrangement of the fibers in the chiasm has been an enigma for the neuroscientists as well as the ophthalmologists. In 1904, the German ophthalmologist Herman Wilbrand, in his book The Neurology of the Eyes, had reported that nasal decussating optic nerve fibers detour into the contralateral optic nerve before entering the optic chiasm. This subsequently was called the Knee of Wilbrand and was the most logical explanation for anterior chiasmal syndromes. The existence of these fibers, the Knee of Wilbrand, has been a subject of controversy. A few studies after Wilbrand's original work did prove the existence of the decussating fibers that travel anteriorly to the contralateral optic nerve, forming the Knee of Wilbrand and then turning posteriorly to the optic tract. The knee became identified with Wilbrand because he was the first to associate it with the characteristic visual field defects caused by parasellar lesions. He stated that, quote, lesions comprising the inferonasal aspect of the optic nerve, just before the chiasm, result in a temporal hemianopia from injury to the crossing fiber. A smaller temporal hemianopia appears in the other eye because of the injury to the knee fibers of the other nerve. If the lesion is large enough, complete blindness in one eye will be accompanied by a temporal hemianopia in the other eye. Close quote. In 1997, Jonathan C. Horton of the University of California published an article titled Wilbrand's Knee of the Primate Optic Chiasm is an artifact of monocular enucleation. Dr. Horton used proline radioautography techniques in rhesus monkeys and squirrel monkeys. In addition, optic chiasm was also examined using myelin stains in specimens obtained post-mortem from 3 one-eyed patients. The patients had lost one eye 5 months, 2 years, and 28 years prior to their death. His conclusion was that in normal rhesus and squirrel monkeys, optic nerve fibers cross the optic chiasm without entering the contralateral optic nerve. After short-term monocular enucleation, fibers from the normal optic nerve were drawn closer to the entry zone of the degenerating optic nerve, but Wilbrand's knee was still absent. After long-term enucleation, a typical Wilbrand knee was induced to form. Wilbrand documented the knee in the optic nerve in 2 patients, both blind in one eye. After degeneration of one optic nerve, the other optic nerve remains normal in size. However, the optic chiasm shrinks. This shrinkage shortens the path of the normal fibers from the intact eye that crosses in the optic chiasm, creating a slack in the length of these fibers. This slack causes the fibers to herniate into the stump of the degenerated optic nerve as observed by Wilbrand. This theory by J.C. Horton thus provides a scientific explanation of the gradual development of Wilbrand's knee occurring in synchrony with degeneration of the optic nerve. Yet another study by Lee et al. Presented 3 patients who were operated upon for parasellar lesions involving the optic nerve near the chiasma. All 3 patients who had no significant vision in the affected eye underwent surgery for aggressive resection of the lesion, including the affected optic nerve at the optic nerve chiasm junction. After the resection of the optic nerve at the optic nerve chiasm junction in the 3 patients, junctional scotoma could not be detected by perimetry, and therefore they concluded that no clinical perimetric evidence was found to support the existence of Wilbrand knee in the anterior visual pathway. For several decades, the knee of Wilbrand was the accepted explanation for visual field defects caused by anterior chiasmal syndrome. With the existence of Wilbrand's knee being challenged by recent research, how do we explain the characteristic visual field defects produced by anterior chiasmal compression? One explanation is the anatomical location of the fibers that cross in the chiasm. The inferonasal fibers, which serve the supratemporal field of vision, cross in the anterior chiasm very close to the anterior notch of the optic chiasma. These fibers travel parallelly to the opposite side before turning posteriorly towards the contralateral optic tract. The supranasal fibers, however, run diagonally towards the posterior part of the optic chiasma and decussate at the posterior aspect of the chiasma. The anterior location of the inferonasal fibers makes them vulnerable to damage from direct compression, stretch, or ischemia caused by the parasellar lesion. A second explanation is afforded by the crossing hypothesis, which states that the parallel arrangement of the inferonasal fibers makes them more susceptible to compression. So, have we totally debunked the knee of Wilbrand? I am not sure. In fact, Jonathan C. Horton states in his article, quote, "Admittedly, I have no direct evidence that Wilbrand's knee is absent in the normal human optic chiasm." Herman Wilbrand's work paved the way for more rigorous research on anterior chiasmal syndromes. Even now, many researchers and neuroscientists believe that the knee exists. Wilbrand's knee has also served a useful purpose by discouraging neurosurgeons from approaching the optic chiasm too closely when resecting unilateral optic nerve tumors. Such a practice is still wise, as Wilbrand's knee may still develop in the optic chiasm of a patient with a unilateral optic nerve tumor like a glioma or a sheath meningioma because of the optic nerve degeneration. Considering all these points, we must acknowledge the fact that we have no direct evidence of the non-existence of the knee of Wilbrand, and that its existence or otherwise doesn't affect the clinical presentation. Even if it does, the concept of anterior chiasmal syndromes may have neither localizing nor prognostic significance other than the presence of a parasellar lesion. But the presence of either the junctional scotoma or the junctional scotoma of trachea should immediately alert the clinician to proceed with neuroimaging. Before I conclude, I would like to summarize what I call as the 3 rules of the chiasma. The first rule is that only the nasal fibers decussate in the optic chiasma. Rule number 2 is that superior fibers maintain a superior position and inferior fibers maintain an inferior position in both the optic nerve and optic tract, irrespective of the status of decussation of the fibers. And the last rule, the rule number 3, is about the characteristics of the decussating fibers. The inferior nasal fibers cross anteriorly and parallel to the anterior notch of the chiasma, whereas the superior nasal fibers pass diagonally and cross posteriorly close to the posterior notch of the chiasma. These three rules will help us understand the anterior chiasmal syndromes which occur because of compression to the optic nerve or both optic nerve and the anterior part of the optic chiasma. When there is a compression of one optic nerve, either nasally or temporally, it could produce a monocular temporal or nasal field defect, respectively. Such a scotoma is called the junctional scotoma of trachea or JST. JST is always a monocular hemianopic visual field defect. When the compression occurs on one optic nerve and the anterior optic chiasma, the resultant defect involves an optic neuropathy or a central scotoma ipsilaterally, and because of the compression of the anteriorly located inferonasal decussating fibers of the contralateral optic nerve, a contralateral supratemporal field defect is seen, and such a field defect is called a junctional scotoma. Junctional scotoma is always bilateral, while JST is monocular. Thank you very much.